conversation about it as well.
Okay. Sounds
so
good.
fast lately, Brennan. Hello. Good to see everyone. I'm so excited for today's talk just because I'm going to speed through intros, Chris, because I know we have 5 million questions for meds. And I have questions. I was thinking this morning, I'm what are the things I want to know? So sorry, I will make sure I get my own questions answered too, which lucky us. But good to see everyone. Thank you for joining. As always, welcome to the Ask the Experts. This is our first Ask the Experts in December, which is crazy to think that there's 3 more before the new year. Time flies, but we love being together and being with you guys. As you know, you can put any questions that you have in the comment box on the right-hand side. Please let us know who you are and where you're joining from so that we can say hello today. Ask the Experts is intended to be educational and to not replace therapy. So as always, if you're in crisis or feeling suicidal, please follow the appropriate resources by calling 988, which is the suicide and crisis line. IOCDF is not a crisis hotline. Chris, I'm going to let you introduce today, and I'm going to get questions pulled up, and we'll take it from there.
Yeah, I have the questions pulled up unless you want to do it. But I'm super excited about today. One thing that we always try to do at Ask the Experts and Lunch and Learns is get a psychiatrist on, because we get a lot of questions about medications. And as you know, Liz and I are licensed, but we're not psychiatrists. We're not MDs. We don't prescribe. It's a very different world, right? There's a different treatment providers for that. So we're always excited to have people on who can sort of answer your medication questions, who can update us on the latest about medications, what's sort of out there, what's the things that you should be hearing from your prescribers. And we are beyond excited. I'm always happy when somebody from the West Coast comes on, because there's always Central and East representation. So I have been super lucky to have Dr. Saxena speak at OCD SoCal events. We've spoken at USC together. We've been able to do a lot of stuff here on the West Coast. So we're beyond excited to have him. He's been a member of our community for a long time. Very expert in this field. Great speaker. And we're excited to have you on today, Dr. Saxena, just to talk about medication, answer some questions, and just to get updated sort of what is the current state of medication and what else is coming up in the pipeline. So thank you for coming out. We're excited to have you.
Well, thanks so much to both of you for having me. I've been looking forward to talking more with people in this setting, and we've done some of these before in previous employers, and it always generates a lot of interest because, as you pointed out, there's a ton of questions out there, and there's a real need for us to get this information out because there are a lot of misconceptions out in the community that you all certainly deal with all the time. So thanks so much for having me.
Yeah, what I'd like to start with, maybe while we're getting the questions, I already see some coming in the live chat. We have a bunch of pre-submitted. But when somebody is, the first question I think is best to, I always get asked this question, so I think it's better for you to answer. When is it time for someone to explore the option of medication? When is it, if somebody is either starting treatment or has OCD, when is it the right time? When do you usually think that, hey, this person would probably benefit from medications or other psychopharmacological interventions?
I think that, that decision is based on a lot of different factors. And it's something that a given person with OCD or a related disorder needs to talk over with their clinicians and kind of determine together, because it depends probably first on how significant and severe the symptoms are. So how much disability or functional impairment the person is experiencing. But it also depends on lots of other things. It depends on personal preference. It depends on what other treatments are available to the person. So are they in a place where they can get good CBT with ERP or not, right? Or do they have insurance that will cover it or not? Who are they working with specifically? And also, what else is going on? So I always, point out that OCD doesn't travel in a vacuum, right? So we know that the vast majority of folks with OCD have other disorders too. And those can ebb and flow in severity. Sometimes they're more severe, sometimes they're less. And so the decision as to whether to go on medications and if so, what medications is based on a lot of those different factors. And oftentimes we'll make the decision as psychiatrists based not only on the OCD, but also what else is happening. Kind of a general rule I let people know when I'm seeing them as patients is that the more disorders somebody has and the more severe they are, the more likely they're going to need medication. In other settings, I tend to get people who are pretty complicated and have multiple different things going on. That may be why they get referred over to specialty centers, right? Because they haven't done well in kind of standard treatment with run-of-the-mill treatment. And those folks virtually always will need a combination of medications and CBT, because CBT can only focus on one thing at a time. You can't treat somebody's depression and OCD and social anxiety disorder and PTSD at the same time with CBT approaches. You have to kind of do them sequentially, because otherwise someone doesn't make any progress. They don't get enough practice in one area. Medications allow us to be a little bit more broad, and a lot of the same medications will be effective to some degree for a variety of different disorders. So it gives you a little bit broader coverage and allows someone sometimes ability to get some improvement in a number of different things going on, and those inform one another. So if somebody gets improvement in their mood, that usually helps their OCD therapy get better. If their anxiety is reduced, that helps other things get better. So it's really a combination, a multimodal approach that I think is best.
I would love to kind of hop in next, Dr. Saxena, and have you just kind of walk through to date. So as of December 6th, 2023, what are the most evidence-based medications for OCD specifically? So we'll start with OCD, but like where should people start? What would be the first line? Like we talk a lot about first line behavioral health being ERP and CBT treatment, and that we know that's where the research shows us you should start today. What is that for medication?
Yeah, I mean, I think the frontline medication treatments for OCD really have not changed all that much in a long time, maybe 20, 30 years. There's been development of the second and third line things, right, and the augmenters. But in terms of first line medications, it's serotonin reuptake inhibitors. So that's a large class. It's a most commonly prescribed and taken class of antidepressants, but they're not just antidepressants. At higher doses, they're very effective for OCD. And so these include the ones that people have heard about most of the time. So Prozac or fluoxetine, Luvox or fluvoxamine, sertraline, which is Zoloft, escitalopram, which is Lexapro, citalopram, which is Celexa, and then an older one, but also very effective in a slightly different class, is clomipramine or anafranil. All of those either have FDA approval in the United States or in Europe or elsewhere for OCD, and they're all roughly at the same level of effectiveness across populations. But a given person might do better with one versus the other. So within those, let's say 5 or 6 medications that are all considered frontline, strongly evidence-based with multiple different controlled studies over the course of many years with thousands and thousands and thousands of participants, and then probably millions of people in terms of real world clinical evidence, right? Because most of these drugs have been around for 30 years or more. They're all roughly about the same level of efficacy, but a given person might do better with one versus the other. So we make the decision of which to start with first based, again, on lots of factors. What someone has had before, did they have side effects, or were they able to tolerate a previous medication? Were the previous ones effective or not effective? And then what is going on currently? What are the person's medical problems, other medications that they're on that might interact with something that we'd want to prescribe for their OCD? Again, other coexisting or comorbid psychiatric disorders, and so on. That really is the front line. The next stage is the secondary medications. So the things that we do, that are called adjunctive treatments or augmentations. And there's a number of different classes there. And the decision about whether to add those on, and if so, which ones, is more complicated, and it involves, again, lots of different factors. But any of the 5 or 6 frontline ones are the place to start.
And so as patients, one of the questions we get all the time is like, what do people do with I don't know if you want to call it like the pushes or the advertisements, or even just the discussion around all these other meds that actually aren't frontline? Like how do you take in hearing about psilocybin or ketamine or these different things that like are getting a lot of buzz? But like as a clinician, what would be your clinical recommendation around somebody who's like, should I start there? Not maybe they say, should I start there? Or they're like, should I try that? Does that work for OCD? Like, what do you say?
Right. No, that's a great question because that comes up all the time. And anytime anything gets a lot of publicity and there's, TV articles that get a lot of press and so forth, it generates lots of interest because a lot of folks are looking for a quick fix or a hot new thing. And what I let people know is that it really depends on whether there's enough evidence for it. And right now, for most of these novel things like psychedelics, there simply isn't very much evidence at all. There's been very, very little work done. There are some ongoing studies now. Chris Pittenger and colleagues at Yale are doing a current study on psilocybin for OCD. Even that, I think, is just an open trial. There aren't, as far as I know, there aren't really controlled trials yet. I'm sure there will be. Those are probably being planned, or maybe they're starting at other centers. But we are really, really early in the process. The initial results from just sort of case reports and a few small open studies look pretty good, but that's a long ways away, probably multiple years away from anything like an FDA approval. That would require much more evidence from lots more studies, especially the more rigorously controlled studies on large populations. And so number one, the data just isn't there for us to be able to recommend it. There's plenty of other stuff that we have really good evidence on that we can recommend well before some of these novel things. Ketamine is something that basically there's two positive studies, both coming out of Stanford, and one study that wasn't so positive. It was a study also from the Yale group several years ago that looked at people with OCD and coexisting depression, and they actually didn't do that well. The two studies from Stanford looked at people with OCD who didn't have significant coexisting disorders, and those folks did well. But even that would be a treatment that would be way down on the list, right? Because it's primarily for people whose OCD has not responded to standard treatments that include not only just standard medications and standard augmenters, but also behavioral therapy. There are a lot of risks and problems associated with some of these novel things too, like with ketamine and like with psychedelics. There can be serious side effects. Ketamine requires an IV infusion and monitoring for side effects. So somebody has to be there in the office with the nursing staff being monitored for several hours afterward. And so these are not simple or easy treatments. I've had a lot of folks come and say, oh, I want to microdose psychedelics. I want to try, either mushrooms, or I'm going to take microdoses of psilocybin that I get from some friend. And they're usually disappointed because the setting also matters, and the framework and the dosing, all of those things, and whether what they're getting from their friend off the street is pure or not pure, whether it contains contaminants. So there's a whole host of dangers. And I really strongly encourage people to stick with the tried and true stuff.
One of the reasons I think, I hear the same questions as Liz, and I think one of the reasons is because people don't have a clear expectation of the way that medication is supposed to be used. So it's like they might have tried an SSRI maybe for like 2 weeks, had a side effect, maybe take one other one, had a side effect or didn't like it or nothing happened, and then are ready to jump to those things. And from what I'm hearing is like those are down the road. Can you talk quickly about if I was to go on medication, let's say I meet with a psychiatrist, what should my expectations be? Let's say, how does the first question, how does a psychiatrist decide which medication? And then second, like, how long should I be on it? When is it time to switch? Like, what should the timeline be so people have good expectations before wanting to jump ship?
Yeah, that's really important. And we try to educate people who are coming in for treatment, as well as any significant other people in their lives, their spouses, families, other clinicians who are working with them, as to the expectations, because they're different than they are for, let's say, treatment of depression or treatment of panic disorder. Number one, the doses are generally higher. So with these serotonin reuptake inhibitors or SSRIs or clomipramine, the doses that are needed for really good improvement of OCD sometimes are 2 to 3 times as high as what they would be for depression. What that means is that people are more likely to experience side effects as we gradually go up on the dose. So in order to get to those doses and not blast somebody with side effects right off the bat, it's a slower titration process. So the two things for folks to remember is that, number one, it's going to take a longer time. A full trial of any given medication we really consider is about 12 weeks or so. And at least half of that, maybe 6 or 8 weeks of that, has to be at a dose that's in what we'd call the therapeutic range. So, for example, if we were using Lexapro or escitalopram, the starting dose might be more like 10 milligrams a day. And the doses that are usually effective for people's major depression symptoms are maybe like 10 to 20 milligrams a day. The therapeutic range for OCD is more like 20 to 40, and sometimes we even go even beyond that to 50 or 60. So it has to be a slow titration. I usually try to get people up to a dose that's within that therapeutic range, as long as they can tolerate it. We're monitoring side effects carefully, usually within the first couple weeks or so, and then we let it wait and see how they do. And then maybe after 4, 5, 6 weeks at a mid-range or low to mid-range dose, we determine whether the person seems to be getting some improvement. Are they tolerating it? If they're not really getting enough improvement, but maybe they've started to, then we may bump up the dose gradually and start getting to the top of the therapeutic range. So it's a longer process that takes patience, and it takes a willingness to experience and work with side effects. Most of the side effects happen early on, right? So as you pointed out, if people get hit with side effects in the first couple of weeks and they get discouraged and they stop, they didn't give themselves a chance to actually improve, and they didn't give themselves a chance for the side effects to go away, because they generally do, right? So if you wait a few weeks at any given dose, most of the time the side effects start to dissipate. For those side effects that don't dissipate on their own, we often have other things that can be done to mitigate them. Antidotes that can help ameliorate some of those side effects. The response rate is slow. So a lot of times people will maybe get a little bit of improvement in the first couple of weeks, but really they're not going to see a more robust, significant improvement that they can really feel until sometimes the end of the first month, the end of the second month. I've had folks who've been on good doses for a while, and then they felt like it didn't really kick in until maybe week 6 or 7, right? The earlier the response is, that's a predictor of long-term response, but it's not the only one. Sometimes people just require a certain blood level and a duration at that blood level to actually get their symptoms to turn the corner and start improving. So it's a partnership. We work with people, and we want a lot of communication and a willingness to work and be patient over a period of time to really get a good response.
I love this. And I think it's just a reminder, for all of us to remember that there's actually no treatment for OCD yet, right? And maybe one day there will be, that's immediate, right? Like whether you're doing ERP and CBT or medication, like it's going to take some times and maybe some augmenting and like getting it right and figuring out what works best for you and what that looks like. And so we say that just because I think sometimes there's this thought process of like, oh, well, I tried it and didn't work. And I've actually found we've had a lot of patients, even here in the res level, where they weren't even giving medication, like they weren't at their effective therapeutic dose, but they also weren't giving it enough time to see if it would work, so we have to be thoughtful of that, even though, of course, we validate and hear that, like, we wish it could work overnight.
Yeah, we get that all the time. We get people, someone will say, oh, I've already tried all those. I've tried 3 of them, 4 of them. And frequently they haven't been at an effective dose, and it hasn't been for a long enough duration. Right?
And so the thing, before we jump into specific questions that there's a lot of, so we need to get to some of those, is I just want everyone to hear too, what Dr. Saxena is saying, that Chris and I are also saying from a behavioral side, is that stick with what's true and tried instead of jumping to what's new and shiny, right? Sometimes these new and shiny approaches, they may be great in it, but our research doesn't back it up yet. And so you're never going to hear any of us up here promoting something that is new and exciting because we think it might work. We're up here promoting and talking about things that are not new necessarily, but they are exciting, but they're researched and they're backed. And we know from science and from, lots of different patient experiences that these are what will have the strongest chance of success. So just want to make sure we all think about that as we hop in. Let's start with 1102. As Spence said, which SSRIs on average cause the least amount of excessive sweating? So that side effect. Any thoughts around that, Dr. Sexton?
So the question was about excessive sweating. And it looks like all of the SSRIs are roughly equivalent to one another in terms of excessive sweating. There isn't any, to my knowledge, there isn't any single one of them that's superior to the others. It's a common side effect, and it's dose related. So as we go up on the dose, getting someone into that therapeutic range, they're more likely to experience that excessive sweating. For most people, it's usually not at the point that's so severe that they have to come off of the medication or they're really, functionally impaired by it. If it's fairly significant, then there are things that we can add on to treat it, right? So there are antidotes that can help decrease the degree of excessive sweating, but they all look roughly about the same.
Okay. Next question at 11:03 from Matthew. I have a question with Zoloft. Can it give side effects of acid reflux? I've been having symptoms with that quite regularly recently.
Yeah, all of the SSRIs and can cause stomach upset symptoms. So they can cause some irritation to the stomach lining. They don't necessarily worsen specifically the reflux, but they can cause.
Sanjay, something am I hearing it? Are you hearing it too, Liz?
Oh, can you hear me?
Now we can. Yeah, something happened. Sorry.
Oh, I see. You know what? I might have blocked the microphone. So all of the SSRIs can cause stomach upset. They can irritate the stomach lining. They can cause nausea, is a really common side effect, as well as stomach pain. And that's why we usually recommend that we take these medications with food, because that will help protect against that. They don't specifically induce acid reflux, but they can go along with acid reflux and cause just sort of general, what we call dyspepsia, or general stomach upset with pain or nausea.
If I could throw out a pre-submitted question, we get this one a lot. This one's specifically about Vyvanse, but it could be any of the medications for ADHD. So sometimes people have both OCD and ADHD. Do medications like Vyvanse, Ritalin, Adderall, do they impact OCD or anxiety at all? And if so, how does someone balance medication management for both OCD and ADHD?
Yeah, that's a really good question, because as Chris pointed out, there are a lot of folks who have both. And that's not at all uncommon to have a combination of ADHD and OCD, particularly for people who have childhood onset OCD. So if you look in the child population, the rates are much higher, maybe 25 to 30% of young people or those who had childhood onset OCD also have ADHD. So we have to be using medication combinations pretty frequently. The general rule is that if a medication improves somebody's ADHD, usually their OCD also improves further, because it helps people not only focus their attention, but also regulate their emotions better. In general, anxiety decreases with effective doses of stimulants. So most of the time we get, and it actually may make it easier for the person to engage in the therapy, because they can concentrate better, they can pay attention. There's some evidence that they may, have a better ability to extinguish fears if they're on stimulants that are helping their higher brain centers work better to inhibit emotion and so on. That's not always the case. So there are some times where, especially if somebody gets too high a dose of a stimulant, that it can induce either physical symptoms that cause anxiety or agitation. So for example, if you're at a dose of a stimulant that's causing your heart to race too fast, or increasing your blood pressure, or causing some tremor, those symptoms can go along with anxiety. They can contribute to anxiety or agitation. Sometimes higher doses of stimulants can make people feel irritable as well. Sometimes they can cause insomnia or changes in appetite, and those things can influence anxiety. I've rarely, if ever, have seen anybody's OCD symptoms get worse on stimulants. However, I have seen what we call body-focused repetitive behaviors get worse with stimulants. So hair pulling, skin picking, other physical repetitive behaviors, nail biting, things like that, those actually can get worse. If people have tic disorders, sometimes, not often, but maybe in about a third of people, tics can get worse, especially if you crank up a stimulant dose too high. But with core OCD symptoms, it's rare that they get worse. Usually, in most people, they actually get better.
It's good to know. What does somebody do if they do have tics or BFRBs and they are taking a medication like a stimulant for ADHD and those things get worse? Is there an option for them, or is it kind of something where they have to balance sort of like the right amount that doesn't impact that but helps with the ADHD?
Yeah, I think it is a balancing act. If the person has good behavioral therapy for their BFRBs or for their tic disorder, that can sometimes be used to deal with any sort of flare-ups or worsenings that they might get in their hair pulling symptoms or their tic symptoms. Or if they're on another medication that specifically treats those, then there's a balance between those specific tic medications or BFRB medications and the stimulant or other medication that's being used for ADHD. So oftentimes, yeah, we do have to balance positive effects and side effects and interactions between those.
The next question, or actually Carrie at 1209 asks, can you list the medications, the frontline medications for OCD again? I think somebody missed it and they just wanted to get that list again.
Sure. Fluoxetine, which is Prozac, fluvoxamine, which is Luvox, sertraline, which is Zoloft, escitalopram, which is Lexapro, citalopram, which is Celexa, and then clomipramine, which is Anafranil.
Could you, a question that I always have, Dr. Saxena, is I sometimes will have clients that have a second medication. Sometimes it might be like an Abilify, a Wellbutrin are the ones that come to mind. How does a psychiatrist know, like, hey, the medication you're taking is effective, but let's add an adjunct medication? What is usually brought on? Well, why is that usually brought on?
Yeah, we use secondary medications or augmentation medications pretty often because this is actually another thing to think about in terms of expectations. Anywhere from 40 to 60% of people on a given trial of a frontline medication don't have an adequate response, right? Partial responses are the rule, not the exception. Really robust responses, like more than 50% reduction of your OCD symptoms, unfortunately, are kind of rare. Remission just with medication alone, a single medication alone, is really rare. So unfortunately, the state of the art of kind of degree of effectiveness of frontline medications for OCD is probably not as good as what it is in some of the other disorders, like major depression, right? If you do serial trials, so if frontline treatment number one doesn't work well, or it's got side effects that someone can't tolerate, and you've given it a full trial, go to number two, right? Try something in a slightly different class, maybe with a different pattern of side effects, but within the same overall category. If maybe two of them have failed, then we might switch to a broader spectrum agent like clomipramine, which has a different pattern of side effects, but it can also be helpful for people who didn't have a response to the more selective ones. If you've tried, let's say, 2 or 3 of these and either gotten minimal response or maybe just a partial response that you want to hang on to, but it's not enough, then we add on augmentations. And there are multiple different classes of medications that have been found to be effective as secondary booster drugs or augmentations. The class of atypical antipsychotics, which includes Abilify, risperidone, olanzapine, quetiapine, a number of other ones, is probably the class that has the best evidence, the most robust evidence, and the strongest amount of effectiveness. However, that class of medications also has its own side effects. And sometimes those potential side effects will limit the likelihood that a physician might want to prescribe them. But they do work. But they're not the only thing that works. There are some anticonvulsants, anti-seizure medications like lamotrigine or topiramate that can be added on. Sometimes we'll use clomipramine or anafranil, not by itself, but in low doses as a booster. So we'll add on a low to medium dose of anafranil onto the SSRI. And there's a variety of other ones, but probably the most effective class are those atypical antipsychotics. The other big reason beyond just we only got a partial response, or we didn't get much of a response at all with the frontline, is comorbidities, right? So if somebody has another disorder that would benefit from adding on that second class of medications, then that may be an effective combination. So if somebody has OCD and bipolar disorder, then we'll frequently add on a mood stabilizer, or they might have already come in on a mood stabilizer and we're adding an SRI medication onto that to try to get improvement in both, right? That's one example.
There was a question from Sam Snell at 1209. Are there any new treatments coming out? I know that there's another comment about like Biohaven. I think they're working on a medication. Is there anything in the pipeline? What's kind of like are there like an active search for new medications or improvements, or what's kind of like on the horizon for that? I know people talk a lot about like psilocybin and things, but medication wise, is there anything on the horizon for that?
Yeah, good question. So there isn't, I don't think, anywhere near enough interest or activity on the part of pharmaceutical companies to study new medications. Biohaven, as you pointed out, is one of the few drug companies in the United States that's actually been focused on trying to develop new treatments for OCD, either new medications that can be taken by themselves or better boosters or augmenters. And most of the work there is looking at medications that affect glutamate, so glutamate modulators. Glutamate is the main excitatory neurotransmitter in the brain. And through lots of research, from animal research to human research to genetics to brain imaging, it's been found that glutamate has a pretty strong role to play in the physiology of OCD. And so glutamate blockers, glutamate modulators have been found to be somewhat effective. Ketamine, for example, is in fact a glutamate receptor blocker. The Biohaven medication was called troriluzole or trigriluzole. The initial large study that was done on that, because our group was a part of that, was not fully successful. There were some people who improved, but it wasn't stronger than placebo across the board in every population. They're changing the study around. They're doing a new one with a larger group and maybe making some changes perhaps to the dosing and other things, and the study design to see whether they can get an effect. So it may be promising, but it's got a ways to go. But there are other glutamate modulators that are being studied by other companies. Some of the medications that are analogs of ketamine. So instead of having an IV, they're either intranasal, or they're new medications that have some of the same effects as ketamine, only in a pill form, and folks are studying those as well. So there's a lot of activity surrounding new glutamate drugs, and I think that's probably the best bet for finding new effective medications that we may end up being able to use, and getting FDA approval within the next 5 to 10 years.
It's interesting. Thank you. I'm learning today, so I'm fascinated. I'm trying to remember everything because, as therapists, obviously we always push our clients to ask their psychiatrist questions, but there's so many things that come up, and I like to at least give people hope. So knowing that there's potential other things, or I think the biggest thing is always reminding clients that, hey, you got to give it some time. What can people expect? Like, how does somebody know? You had talked about it a second ago about like a 40% and how reduction, like what can somebody expect if it's working? What should it look like? So they know they're on the right track with the medication.
Yeah, I think what people often, there's a timeline, and I see this over and over and over again. The first kind of early sign that you're more likely to be getting a good effect, or the first good effects that somebody experiences, are usually kind of just a general reduction in overall tension and anxiety. And that sometimes can start even within the first couple of weeks if you're lucky. Then as we go on, continue up on the dose, or someone's just on that particular dose for a longer time, we usually will see depression symptoms start to improve as well, kind of in the typical time course as we'd normally see depression symptoms, maybe within the first 3 to 4 weeks. The more robust or significant improvement that are really noticeable in core OCD symptoms sometimes takes a little bit longer. So again, some people will start to notice something within the first few weeks. Other folks may not really notice much change until maybe the end of the first month, maybe into the second month, and then it gradually builds over time. So as we said, a full trial usually requires at least 12 weeks. Most of those 12 weeks have to be within the therapeutic range and sometimes higher. But then if you follow people out, so let's say the person is on that same medication for a year or 2 years, what you usually see is gradual further improvement over the course of the year.
Specifically, when you talk about improvement, I should have been better with my question. A lot of times people are like, what should I expect? Should it be a reduction in urges, less frequent thoughts, quieter thoughts? Like, what are some of the signs people know, like, okay, I'm experiencing this shift or change?
Yeah, we would look for all of those. So, as I said, probably the first thing is the reduction of anxiety and tension and distress that comes from the thoughts. Even if they're still having the thoughts, as you said, are quieter, they're less intense. I've had people say, I'm still getting all those obsessional thoughts, but now they're not yelling at me more. Now they're just talking to me. Or maybe later on, now they start whispering. Longer into the treatment course, you actually should start seeing a reduction of the thoughts themselves. So less frequent obsessions, less intense obsessions, and a decreased distress from those, and then an increase in your ability to resist compulsions or resist avoidance. Right. So all of those go together.
Okay. I like that, because sometimes people are like, what do I look for? And I think you just answered it beautifully. Thanks. There was a question from Amy at 1210. She says, how common is it for numerous psychiatric meds and their combinations to be ineffective, like for OCD or treatment-resistant depression? So sometimes we'll get this where somebody says, look, I'm like absolutely like medication resistant. Like, is that a common thing, or does typically some kind of medication intervention end up working for people?
Yeah, I think the answer to that depends on how aggressive their treatment has been and how many different medications they've tried. So with each subsequent trial, you have another incremental percentage of people who will improve. So as I said, with a single trial, if you look at the clinical studies, maybe about half of people will have a significant response, and maybe an additional smaller number of people will have, a partial but not really fully adequate response. If you do serial trials, let's say you try the second SSRI or the third SSRI, maybe you can get that overall percentage up to 60% or more. There's still probably going to be roughly around 40% of people who just don't get enough of a response that's really adequate to any of the SSRIs. And then we think about the augmentations. Adding on augmentations, again, any given trial usually produces a response in a roughly about a third to a half of people who take it. So, when you add on a second medications like Abilify or risperidone or something, you can, let's say, convert maybe about a third of the people who were unresponsive or minimally responsive before into responders, right? So that increases your percentage even more. If you've now tried multiple classes of augmentations along with multiple frontline ones, usually you can find some combination that's going to be effective. So if you're trying out, adding on clomipramine, adding on atypical antipsychotics, adding on an anticonvulsant, trying some of the fourth or fifth line ones. If we keep going through the algorithm and trying different categories, usually we'll be able to find something. So it becomes pretty rare. Maybe, it's hard to give a percentage. Maybe, 15, 20% of folks, if we've gone all the way through a pretty extensive algorithm of multiple different classes of medications to get somebody who really hasn't responded well to any of them, right, or any combination thereof. And so luckily that's small, but it takes work and patience to keep going through these trials. And it takes being treated by somebody who understands OCD, who really knows what to do and what medications to use and what doses to use and how to deal with those side effects.
So that would be maybe when somebody start looking at TMS or some of these other options people are hearing, if they're just absolutely not finding any success after all that.
Yeah, I think the most successful and effective and important augmentation to medications is behavioral therapy. Right. So when people say, well, I haven't responded well to SSRIs, what should I do? The first and most obvious answer is you got to get ERP, right? And CBT. And so the percentage of people who don't respond to combination of even frontline medications and CBT with ERP, if it's done effectively and correctly, is much lower, right? So the percentage of responders, once you get to combinations, and proper treatment, what I consider proper treatment with a therapist who understands OCD, where somebody is actually doing behavioral therapy, homework exercises with full exposure and response prevention, the response rate is going to be much higher. The percentage of people who don't get a good response when you really do the treatment properly is much, much lower. So before I recommend going to TMS or to deep brain stimulation, or even to some of these novel medication things like ketamine or psilocybin and so on, is going to be much, much lower because, again, just like you and Liz mentioned, you stick with the tried and true stuff. And the vast majority of people, if they get proper behavioral therapy along with effective frontline or evidence-based medication, are going to respond. If they don't respond well to standard outpatient behavioral therapy, we increase the intensity of that. You're going to get a bigger bang for your buck by getting more intensive behavioral therapy than you are by adding on the next class of medications. So we bump up to intensive outpatient, up to partial hospitalization, even up to residential, right? Now, unfortunately, that's not always easily accessible or easily available. Not every city has intensive outpatient programs or partial hospitalization programs, but I would highly recommend those because, again, those are, and the data shows this, they're much more likely to be able to help convert somebody from being a non-responder to a responder than any augmentation of medications that you can think of. Right?
I'm glad that you brought it back to the behavior, because I think sometimes that's what people don't recognize is like if you're, getting some success with medication, we have higher levels of care. Obviously, Liz runs a very effective one. There's intensive outpatient, there's partial hospital. And I think that that's really the key. I think sometimes people, and I'm glad that you explained sort of what the medication can do, because sometimes I think people also have specific hopes. Liz made a point earlier, we're not at that stage yet, right? That we see immediate shift where somebody takes a medication, they have almost like a reduction of 100% of symptoms, et cetera. So I think it is work, but I hope what people are hearing is there is effective stuff out there. People are getting better. We just gotta, I always joke with my younger clients, I'm like, OCD treatment isn't like 2-day delivery from Amazon. Like you got to put some work in. I wish you could just order and have that, like what the slippers you ordered or whatever, like, within a day or two, but it puts in work. And I tell people it's because you're learning a new language. Like you've been so under OCD spell for so long, you're almost reteaching yourself how to function in a non-panic, obsessive way. So, give it time, but it's effective.
Yeah, and I try to remind people that this is not unusual. It's not like treatment of OCD or treatment of depression is all that different from treatment of anything else in medicine, right? If you have serious hypertension, the first drug may not be helpful, right? Cardiologists and primary care docs frequently will need to layer antihypertensives and get a combination of medications to get improvement, and it doesn't happen right away, right? So a lot of times you have to wait, 6-12 weeks before you get enough improvement. Even infections, right? So serious infections may not get better with, 5 days of an antibiotic. Sometimes let's say, bad sinus infections, you might have to be on an antibiotic for 6 weeks, right, to get an improvement. Diabetes control, other, treatment of autoimmune disorders, treatment of migraines, epilepsy, they take time and they often take combinations. So this is not at all unusual. I think part of decreasing stigma and educating people is to remind them that the things that they should expect with treatment of OCD with medication are not really different, and they shouldn't have a different set of expectations for psychiatric disorders than they would, with their anticonvulsant. So I frequently will get people saying, "Oh, I don't want to take that because it has side effects," and I said, "Well, okay, if you were coming in for treatment of epilepsy, right? how worried about side effects would you be? I mean, yes, we obviously are concerned about serious side effects or long-term side effects, but we have to balance that against the effect that we're going for.
That is beautifully said, because I think we don't think of that, right? Like we recognize, like I have kidney stones, and one of the medications I take for it kind of flushes stuff out. It makes me have to use the restroom more frequently, but I don't get mad at that, right? Like I understand why it's happening, and I think that's sometimes what you said really well is that in physical, like when we have a loved one going through cancer, we don't expect it to be an overnight fix. We know it's a process. And I think if people can have that same patience, like we get it, Liz said earlier, you know, we validate the struggle and the difficulties of trying different medications or like wanting quicker answers. And if you can hang in there, just like you do when there's a physical ailment, it will eventually, you'll find the right thing for you. One question that I think Carol brings, it's a good one at 1224, Brennan, is how do you know when you've reached the best dosage? She's talking specifically about fluoxetine for her 9-year-old, but in general, like how does someone know that they landed on the right dosage for medication?
It really depends on a balance between positive effects, so improvements in their symptoms, and side effects. What a lot of psychiatrists will do will be to do this gradual titration. As I said, we might try to get someone somewhere, you know, maybe to the low end or the mid end of the therapeutic range, as long as they're tolerating it, and give it some time, right? And go, you know, 8, 10, 12 weeks. And then if someone's getting some improvement but not enough, we gradually increase. And with each increase, we'd monitor carefully for side effects. We'd give the new dose a little bit of time as well. When you bump up, let's say you're bumping up from 40 milligrams of fluoxetine up to 60. Again, you're not going to see an improvement tomorrow. You're going to have to wait several weeks and see. Let's say I give 4 to 6 weeks or more at the new dose. Okay, is that going to be effective? If I'm getting some incremental improvement and I'm still tolerating it, okay, then we might bump up to the next level. Then we go to 80 and try that for another 6 weeks or 8 weeks and see. If at any point along that dose titration, the side effects become too burdensome, then we have to back off, right? So it's oftentimes a process of monitoring both and trying to find the best balance between positive and negative side effects. And then that same thing is true when you add on an augmentation.
One question that we got at 12, or I'll let Liz ask it.
Sorry, it's like so hard for us to be like, who's asking what, and going back and forth. So the next question at 1226 that we're going to throw your way, Brendan, from Rahul is, what do you have to say about using supplements like ginseng, ginkgo, rhodiola for comorbid ADHD along with OCD treatment?
Unfortunately, and I followed this literature for a long time, there are no supplements that have been found to be effective for OCD. A few things like, with one possible exception, which would be N-acetylcysteine, or NAC. That's an over-the-counter supplement, and there have been some studies of NAC, not as a medication by itself, but as an add-on, as an augmentation to SSRIs. Some studies have been effective for that. The data is mixed. There were a couple of studies that didn't find any difference between NAC and placebo, and then there were about 2 or 3 studies that did find it a significant improvement with adding on NAC versus adding on placebo. So that's really the only supplement or over-the-counter agent that's been found to be effective for OCD symptoms. Some of the other ones that you just mentioned, like rhodiola. Rhodiola was found, at least in a small study, to be effective for general anxiety. I don't think that was ever replicated. So, you know, the data is maybe like 10 or 12 patients period in terms of published studies, but none for OCD. Also none for ADHD. So things like ginkgo, there was a lot of interest years ago in ginkgo biloba for sort of concentration and memory. And it didn't really seem to really pan out. A lot of the formulations of ginkgo actually had caffeine in them. And that's what helped people, you know, feel more awake and alert and improve their energy. It wasn't the ginkgo itself. So I don't know of any over-the-counter supplements that have been found to be effective for ADHD, you know, with except for caffeine, essentially, right? You know, temporarily improving alertness and concentration.
Yeah, I haven't heard about ginseng since high school. So when I read that, I was like, oh, I forgot about ginseng.
Right.
Yes, a couple of people are commenting that they actually have tried some and some supplements and that they didn't help. I'm curious because one thing we hear a lot about is not a posted question is individuals asking about the impact of like exercise, so diet and exercise and healthy eating and all of that and the impact that might have on OCD and OCD treatment.
Yeah, so exercise is the one that's probably been studied the most. And there are a few studies going back over the last 10, 20 years showing that adding on a consistent exercise regimen can boost the effect and improve OCD symptoms when added on top of medication treatment and behavioral therapy. And so that's something that we recommend for everyone, just for general health, but also they may get some specific effect. Exercise has definitely been found in lots and lots of studies over many years to be effective for improving depression symptoms and probably reducing general anxiety. But there's a couple specific studies with OCD that showed a positive effect. Dietary changes, unclear. There are some findings about what types of diet are best for preventing relapses in depression or having some mild mood improvements. And that's usually this anti-inflammatory diets or Mediterranean diets are the same types of diets that are best for decreasing the rate of hypertension or heart disease or diabetes, right? Those diets are also seemingly good for decreasing the rate of depression. I'm not aware of any research that showed that any dietary changes affected OCD symptoms.
Yeah, we did I did a talk this summer at the in-person conference. It was with a registered dietitian, a bodybuilder who's also a strength and conditioning coach, a yoga and meditation provider, and then I've done a lot of research on sleep because I have a sleep disorder, and you do see that there's like an overall increase in just being able to handle stress and like general wellness. And I think sometimes I'll never forget, I had a client that's really struggling with OCD, and he came in one day with like a 7-Eleven Big Gulp, and I was like, "What's in that?" And he's like, "Oh, I put Mountain Dew in half and then mix it with Red Bull." And I'm like, "You're asking me why you're anxious all the time." And I did like a diet kind of, I always do that with clients, right? Like caffeine intake. But I think sometimes people forget that when I say caffeine, I don't mean coffee, right? But I was like, of course you're anxious. Like drinking that, I wouldn't sleep for 3 weeks, right? Like I'd get my first good night of sleep in 2027. So I think sometimes people don't recognize that maybe some of those kind of habits can contribute. Not that a diet will necessarily reduce intrusive thoughts, but I know that when we're well rested, we get some exercise, we sleep well. I think of it like you talking today, it's like a holistic approach, right? Like you really got to make sure you're working with the right provider for your behavioral health, behavioral treatment at the right level. You want to make sure you find a psychiatrist that understands medications. And then there's a component of like general support and wellness. And when all those things come together, that's probably going to be the best chance that you have to really, fight this thing. So
yeah, and I'm glad you brought up sleep and energy because those are major factors. So, sleep disorders of any kind, but really common ones like obstructive sleep apnea, have a huge effect on neuropsychiatric symptoms, right? And oftentimes a sleep disorder can be the reason why somebody has treatment-refractory depression or treatment-refractory anxiety disorders. And certainly treatment-refractory ADHD, or it can mimic ADHD, right? Because if your brain is not getting enough oxygen for multiple hours overnight, it's not going to function well the next day. So yeah, working on overall life habits, improving the quality of sleep and the duration of sleep, teaching people proper sleep hygiene goes a long way to getting improvement in their mood symptoms as well as their anxiety and OCD symptoms. Eating properly, not getting fatigued. Most people with OCD will have told me that as the day gets longer and longer and they get closer and closer to bedtime and they get more and more tired, it gets harder and harder to inhibit your compulsions, right? Or to inhibit the anxiety. And then it's a vicious cycle because The more tired you get locked into OCD symptoms, and then those make you stay up for a longer time, which means you get less sleep, which means you get more tired, and it goes on and on and on, right? So really optimizing general overall health and well-being is a critical thing to get improvement to anything else. And that includes sleep and diet and exercise.
And not drinking big gulps of Mountain Dew. I was like, first of all, Mountain Dew like glows in the dark. It scares me. There was a question at 12:45, Brennan, from Can TT. This is a question I get from a lot of clients. Obviously people think of like, okay, OCD, I take a medication in the morning. What about people whose minds are racing, before bed, or a lot of their OCD and anxiety comes up right before sleep? Should that have anybody adjust when they take their medication? Should people be taking it at night if that's the case? Like, how do people utilize medications if somebody's mind is racing or their symptoms really hit them at night?
Yeah, the frontline medications for OCD and even the augmenters or second line medications are also not things that kick in immediately, right? As we said. So certainly, the choice of whether to take medication in the morning or at night really depends on the side effects of that medication. So some of the SSRIs and clomipramine can be sedating. So preferentially recommend people take them at nighttime. Others of them tend to be more activating and can cause insomnia. So we recommend those in the morning. So on average, escitalopram or Lexapro is usually more activating. So I almost always will give people in the morning. Sertraline is kind of mixed. It can, as with Zoloft, it can be either way. I've had an equal number of people say it causes insomnia to those who say it causes sedation. Celexa or citalopram tends to be a little bit more sedating. I almost always will have people at least start that at nighttime. Fluvoxamine or Luvox, also probably a few more people get sedated from it than get activated from it. So the first step in picking medication timing is just based on the side effects of that medication in that particular person. And it varies a lot. So I might have said like, okay, Prozac tends to be more activating, but about a quarter to a third of people with Prozac get sedated from it, right? So you have to look at what's going on in that particular person. But I wouldn't be taking those medications specifically for racing thoughts or nighttime anxiety, right? Because they're not necessarily they may have a mild sedative effect if they're one of those that's sedating, but that's not really going to do that. I wouldn't recommend using long-term sleep medications just to deal with those things, right? So if somebody is taking Ambien or wanting to take something like Klonopin or temazepam or Restoril at nighttime to try and calm down their racing thoughts, that may be temporarily effective, but those effects usually wear off. And for insomnia that's related to racing thoughts and anxiety, the most effective treatment is iCBT or CBT for insomnia, right? So relaxation exercises, deep diaphragmatic breathing, progressive muscle relaxation, and the other components of some of the cognitive restructuring components of iCBT are much more likely to be effective and to remain effective over time, right? So racing thoughts at nighttime is a symptom of other disorders, a typical symptom of generalized anxiety disorder. It's also pretty common in OCD. The key is to treat the underlying disorder before you focus just on, okay, what do I do about those racing thoughts, right?
Yeah.
And to use broader treatments that are more likely to be more broadly effective.
I want to sneak in a real last question because I saw three times about if people are on adjunct, rather antipsychotic. A lot of people are saying it makes them really, really tired. Is that something you hear commonly with antipsychotics, using an adjunct with an SSRI, like the tiredness? And is there anything that someone can do to address that?
Yeah, so just like the SSRIs can vary in terms of ones that are more activating versus ones that are more sedating, it's true for the atypical antipsychotics as well. So some of them are really very sedating. Olanzapine or Zyprexa, quetiapine or Seroquel are highly sedating medications. So almost always we'll give those at nighttime. With Abilify, it tends to be a little bit more activating. So there's some folks who can get insomnia. Some people get some physical agitation, feeling of restlessness. So I generally have people start with in the morning. Risperidone usually tends to be making people more tired. So we can switch around between these. If you try the first one or the second one and you're getting a lot of fatigue when you add it onto an SSRI, then we may want to switch and try one of the ones that's less sedating, like Abilify, or some of the newer ones like Vraylar or Brexpiprazole, which is similar to aripiprazole. Those are the three that probably are more likely to be activating and are less likely to cause fatigue. The other thing to work with is dose, right? So, regardless of which one you're on, if you get to a certain level and it just causes too much tiredness, you have to back off. And that's true with SSRIs, and it's also true of the augmentations, whether it's an antipsychotic or an anticonvulsant. Virtually every medication, when you get too high a dose, can sometimes produce fatigue.
Thank you so much. I can't believe we're at time. I'm like frantically, if people see me frantically doing something, I'm copying and pasting all the questions we didn't get to put it to our list. So that what we always tell our guests like this on Dr. Saxena is when we don't get to all the questions, and I'm frantically copying and pasting so that people who ask questions don't have their question get wasted, it means we need a part 2. So we will definitely have you back on. Liz, what are just some, like, if you were to summarize what you learned today, like what are some of the things that you really hope people take from this live stream today?
I love it so much. And what I love, Dr. Saxena, is like every question you had a specific answer that was quick, and like you gave it based on research. Like I just want us to remember that, medication and therapy should not be something that we're just guessing and that we're trying. And the great news is we don't have to. Like, research has been able to inform where we should start and what we should do. And what you've been able to hear today is there's really clear guidelines on, like, here's where you start, here's what you do, but then here's when you might consider other things and what that might look like. And so be sure to follow the research and the clinical experts' guidance on this so that you can get the help that you need. As always, what we know is that the most effective treatment for OCD is a combination of medication and behavioral therapy. So we're hopeful that this has been helpful. And yeah, there's like 5 million questions we didn't get through today, and they're submitted, so we need you on like once a month. So who knows what'll happen in the future? Maybe that'll be the case.
Yeah, no, we should definitely do it again, because I agree with you. Every time we do some of these sessions, whether it's at the conference or in other settings, Facebook Live and things like that, there's never enough time. There are always more questions. So there's obviously a huge desire for information and a huge need to get questions answered.
Absolutely. Well,
yeah, I'm frantically copying him. So I promise you, if you asked a question and we missed it, we will definitely ask it at a future stream. So please, when we have Dr. Saxena back, make sure you join us. Well, thank you everyone for coming out. Make sure you always come by. We have these live streams every week. Liz and I will be back next Wednesday. Make sure that you come by. Or actually, next Wednesday is Research Roundtable. So Liz and I won't be here, but Dr. Abramowitz and Kyle King will be. But we'll be here the rest of Wednesdays at 9. Thank you, Dr. Saxena, for having us on. It's always good hanging out with everyone in the community. And come back. Come hang with us in a future live stream. Thanks, everyone.
Definitely. Thanks for having me. Take care.
Thanks, Dr. Saxena.